Who would want to take this question for us? Okay, let me read myself. The client is being discharged after a left modified radical mastectomy. Which discharge instructions should the nurse include? Select or that apply. Who wants to try? Who wants to try this?
For 1, 2, and 5. I don't know.
1, 2, and
And 5.
5. Do we all agree? One, 2, and 5. Okay, I agree with you. Silence means consent. It means we are all okay, right? Yes, I agree with you. So,
No.
so let us hear from you. Why don't you agree? Which parts don't you agree? Or if you have a different option, you can bring it up. The first one says notify your healthcare provider of temperature of 100 degree Fahrenheit, which is the same as 37.8. So consider temperatures um, from 37.8 going as a sign of infection. Okay. Yeah, so don't wait to see 38.0 or above 38 before you think it's infection. When it comes to situations like this and chemotherapies and and radiotherapies, people undergoing procedures that affect their immune system. When you have temperatures of 37.8 and above, it's an issue. It's a sign of, or it could be a sign of infection. Okay. The next one, you're saying carry large purses and bundles with the right hand. We established the fact that if you if you have, let's say, left radical mastectomy on that arm, you shouldn't use to carry objects which are heavy. Okay, look at this option. Carry large purses and bundles with the right hand. So this is a correct instruction because the mastectomy was done on the opposite arm, which was the left. So even if it's a tricky one, okay. So if you have something which is even heavier, you can use the right arm. Okay, the opposite one, not the very one that had the radical mastectomy on. Okay, so that's why option 2 remains correct. Option 3 says do not go to church or anywhere with crowds. This is when someone has mastectomy done, doesn't mean the person is neutropenic. This will apply for someone with neutropenia, let's say with absolute neutrophil count of, let's say, less than 500 or 500 or less. You've studied neutropenia, right? Especially not our newbies, but those who are old. I hope I hope you've met neutropenia and their precautions, what to do for them, and how to educate them. So this option will work for someone with neutropenia, not someone who had mastectomy. Okay. The fourth one, and I think neutropenia to when someone has white blood cell count of less than 3,000. I think that one too will also apply. Okay, for this person. Try to keep the arm as still as possible until seen by the healthcare provider. So this one looks tricky. Remember, they will always polish the wrong answers to you. Okay, they'll polish it in your eyes for you to think it's correct. Keep it elevated, not still. And you should perform maybe range of motion exercise or um, exercises like the other ones that we talked about. You remember the last time, isometric exercises. Good. So not to keep the arm still. If you keep the arm still without moving it, you get lymphedema. Okay. So that makes the discharge instruction wrong for option 4. Then have a mammogram of the right and left breast yearly. So we are going to talk about this maybe in a bit, right? But one thing about mammogram is that people who are, I'll say it again when we get there, but people who are susceptible for susceptible to these conditions, okay, or someone, remember when someone has had um a cancer or a tumor removed, like a breast cancer or tissue removed from mastectomy. Remember, they they remain higher risk of maybe the thing happening again, especially to the other breast or something like that. So with that one alone, having a history of a tumor removal subjects them to like having a high risk of it. So when you have high risk of breast cancer, it is always recommended that you have your mammogram every year. But before that, remember, if you have like averagely, if you have an average risk of these breast cancers, actually mammogram start at 40 years. Okay, at age 40. Mammogram starts average. If you have average risk, it should start at age 40 and should be done every 2 years. Okay, until you get to somewhere 70, 74 that way. Okay, it should be done every 2 years. It starts from 40. But if you have, let's say, a high risk, like if you had mastectomy done before because of, um, let's say, breast cancer, then because you have high risk, you have to at least do it every year so that we can screen you and make sure we put in measures to prevent it resurfacing. Okay. And if let's say you are less than 40 years and you have issues with breast, most of the times it's ultrasound that they normally do to fish out what is happening. Okay. It's unlikely for them to do mammogram on you, especially diagnostic. Okay. But if let's say you happen to get mastectomy done at age 30 or maybe less, irregardless of or let's say regardless, or irrespective of your age, you have to do this yearly screening. Okay, yearly mammogram screening. So take note. They can ask you these questions I've just said. So take notes of the timings. Okay, it is very important. Any question on this one? So that's why the answer remains 1, 2, and 5. Okay, 1, 2, and 5. Any question? Okay,
Then,
so that's the answer. Yes,
please, what about the 4?
option 4.
Mm,
So that was what I was explaining, that try to keep your arms still will increase your risk of lymphedema. Remember I said that right now. And I mentioned you have to elevate it and also do isometric. Someone even said isometric exercises.
yeah, yeah.
Uh-huh. So you
Okay.
don't have to keep it still. Keeping it still will increase your risk of lymphedema.
Okay. But why is it that people less than 40 we cannot do mammogram for them?
I don't know. I don't know that. I think that's the rule. It's like colonoscopy too. You can't do it unless they, I think, is it 45 or 40 that way. There are some procedures. I don't know why, but maybe because of the risk, they
Yeah.
come along with.
Okay.
Yeah. So for screening wise, where you go right now, even if you have, let's say, you have a possible, God forbid, let's say if you have a possible breast cancer or something that they suspect, they will never, no radiologist will go ahead and just do mammogram for you. They will do ultrasound first. Okay. So they normally do this mammogram for people of that age, 40 and above, you know. They'll never do it for you if you are less than that. Or unless maybe there's something you have history and that you are a candidate, like a registered candidate, and we are doing it for you like yearly basis or something. But if you are afraid, they'll never do it for you. Okay, any other question? Someone works with our breast department over here, right? Mammography. Someone works with, I think last week we had someone, I think two people or so contributed. Are they here? Can you tell us more? Okay. If they are not here, let us carry on. So there is something that I want us to also pay attention to. We call this I call this ABCD rule. Okay. I call this ABCD rule. So this ABCD rule means asymmetry, border, color, diameter, and evolving. So this is used to describe characteristic of a mole, or if let's say you have let's say something developing. Okay, let's say you have a mole developing MOLE. Okay, you have a mole developing or something like a node or something. Yeah, a nodal or a node developing, or how should I even put this? Yeah, I think the best word I can use. I want to find nearest in meaning for this, but let me use the word the mole. Or you have a mole developing on your body. How you can know that this mole is cancerous, or how you can suspect that whether it is cancerous or not. We have this ABCD rule to fish out. And this is also, pay attention to it very well because it's also testable. Okay. Those of you who have seen questions on it before, you appreciate it. Let me show you. Let me see. Let me see if I can show you a mole. Okay. Let's see. MOLE. Oh, not an animal. Okay. So I think, yeah, look at this one. Oh, the picture. So let's look at my right hand. Okay, my right hand side. Let me use my pen here so that you can see it well. Have you seen this one? Okay, so it looks like something nodular or yeah, something like that. So when you have things like this emerging from your skin, okay, how you can tell whether that thing will become cancerous or it is capable of becoming cancerous. That is how, that's what you are going to talk about. Okay. Yes. or when you have, let's say, a flap of tissue, like abnormal tissue, something like that, emerging from your skin, how to know that it could become cancerous or not. I hope you understand what you are trying to say, right?
Yes.
Okay,
Yes.
okay. So let us go back to our slide. So we are saying changes in the size, shape, color, or feel of a mole are often the first warning signs of melanoma. Okay, like skin cancer, type of skin cancer. These changes can occur in an existing mole or melanoma, or melanoma may appear as a new or unusual looking mole. So let us start the whole thing again. So what we are saying is that changes in the shape, color, size, or feel of a mole are often the first warning signs of melanoma. So these changes can occur in an existing mole. So a mole can be there where it can appear or it can change to be a one that is capable of causing harm. Okay, or you can have a melanoma which appears as a new or unusual looking mole. Okay, so sometimes when they begin, they look like a new and not harmful one. But how you can determine if it's a cancerous one or not is what we're going to talk about. Okay. Okay. So the first one we are saying the ABCD rule is helpful in remembering the warning signs of melanoma. Okay. The first one is asymmetry. So what this one means is that um, the shape of one half of the mole does not match the other. Okay. The shape of one half of the mole does not match the other. Let me try and draw something here for us to appreciate what you're talking about. So let's say the shape, if let's say you have a mole like this, okay. Let's say if you have a mole like this, when you divide it into two equal parts like this, one half does not match the other half in terms of the shape. So that is the asymmetry that we are talking about. Okay. So the shape of one half of the mole does not match the other. So this is one thing to look out for, to suspect that it could be cancerous. Okay. All right. Now let's look at, do you understand that one? Before we look at the second one. The second one says border, which explains that the edges are, how do you pronounce this word? Is it rigged or ragged? Hmm. Then they are notched. Okay, they are uneven and they can also be blurred. Okay, so um, look at, let's if you have let's say a mole like this of this shape. Okay, or let's say a mole of this shape. So it can be either the first one I've drawn, this one, or this one, the second one. So you can see that the edges are very uneven. Okay, most of the times those that happens not to be cancerous, they will have fine, well-defining edges. Okay, like if it's round, it's round. If it's like a square, it's like a square. Depend. So it will not be like it will not have uneven. borders or something like that. Okay, or notched borders. So if you have a melanoma, or let's say if you have a mole of which you can suspect to be cancerous or a melanoma, watch out for the edges, so I mean the borders. Okay. Yes, so they don't have a fine border. Their borders are uneven, blurred, they can be notched. Okay, like how I've demonstrated here. Then the next one is the color. How will you see them in terms of color? So you are saying you can have one mole, okay, and they can have series of colors.
Place. Police station.
You can have shades of, you can have shades of black, brown, tan, like different colors may be present. So you have one mode. So instead of, let's say, everything becoming brown or black in color, you have something like black, brown, tan, sometimes, gray, red, blue, and have like different areas of that same mode having displaying different colors. So that should tell you that that mode is highly, or is I mean the chances of being cancerous is very high. So that's also one thing to look at. Okay. Now the next one is the diameter of the mole. So the diameter of the mole is usually larger than 6 millimeters. This one you have to keep it. Should you get questions on it? But questions I've seen on the diameter aspect, they normally use this one. This was what I saw about the size of a pencil eraser. Mhm. So take note of these keywords, okay? 6 millimeters, or about the size of a pencil eraser. Okay. Yes. So take note of this. So we are saying the diameter is usually larger than 6 millimeters. It's larger than 6 millimeters. So if, let's say, you have a mole like this, an expert can measure the size of the diameter. So if the diameter is normally larger than 6 millimeters, then it can be a mole, or it's likely to be a mole. I mean, a cancerous one. That is what we are talking about. Okay. All right. Then the last one here is evolving. We are saying the mole has, if the mole has been changing in size, shape, color. So at a point in time, the mole was black, and sometime later, it changes to blue, like the whole thing. Okay. Or it changes to gray, you know, in how it appears, and like the shape and everything. Then that is even an easy way to note that that will be cancerous. Okay. So that is how you can note if you have a mole developing and has high chance of becoming a cancer. And we also said that when melanoma develops in an existing mole, it means if you have, let's say, a fine mole which is even uncancerous, then you have melanoma developing out of it. The texture of the mold may change and become hard and lumpy. Okay, so let's say a fine skin, uh, like a fine skin mold. Okay, a fine skin mold which happens to be very smooth, like a flat one. Okay, if, let's say, um, God forbid, melanoma happens to come out of this, or this happens to change into a cancerous one, this is what we are saying. You have the texture changing, okay, and you'll see it becoming very hard and lumpy. So instead of um, the smooth texture of it, you see it becoming lumpy and hard. You'll see it very different from how it was before. So that's how you know that it can become cancerous. Okay. So we are saying the skin lesion may feel different and may itch. Sometimes it may itch, ooze or bleed. Remember the last time I told you when you have bleeding in some areas, especially where you have or if you have a high chance of getting cancer elsewhere or anywhere and you find bleed around that area, don't sit on it. Okay. That could be um, a high alert sign for cancer. They are saying, but melanoma skin lesion usually does not cause
Please
pain.
come again.
Okay. This one, we said it like last week, we said it that if it's breast cancer, whether it's cervical cancer, if you have high risk and you find some blood, like you find bleed from those places, there's high possibility of cancer over there. We said it last week. Yes, so I'm just reminding us, okay, that yes, so it's the same thing over here. Okay, and we are saying that normally for melanoma, um, it does not cause pain. Okay, yeah, and most cancers, most cancers, when it comes to signs and symptoms, you will not have pain. It doesn't mean that you won't have pain for all cancers, but most of them they are painless. But the bleed, you have the bleed. Okay. Any question on this one? I think there were a lot of questions on this one, but I didn't bring them here. Maybe later we shall talk about questions on this one. But if you have questions, you can ask. Before we
Please, can I see the slide before? Please,
this
sir.
one,
Can I? No, the other one. The
this one,
previous one. No.
this one.
Mm,
This is the only thing we were talking about.
yes, that's it. That's it. Thank you.
Mhm. Okay. All right. So let's talk about a bit on chemotherapy. Okay. We have oncology lesson we shall talk about sometime later indeed. But as part of fundamentals, let's talk about chemotherapy in a bit. What is chemotherapy? When we say chemotherapy, what comes in mind? What comes in mind? I think for every nurse, we all know about what chemotherapy is, right? So
Mm-hmm.
we use
Treatment for
Chemotherapy
instead of cancer.
is used.
oh sorry, I was meeting half people because I thought maybe it was a different sound from somewhere. Sorry. So chemotherapy, we use drugs, I mean the use of drugs to treat cancer. Okay. The use of drugs to treat cancer. And those drugs normally have high toll on the body, causing a lot of issues. Okay. So we have to know about this and know how to manage our patients. One thing you have to know about chemotherapy drugs is that they can cause bone marrow suppression and tumor lysis syndrome. You remember tumor lysis syndrome? What is tumor lysis syndrome?
Breakdown of the tumor.
When the tumor cells break down and release chemicals into the body.
Good. Tumor lysis syndrome is characterized by, is it four main features. What are they? Yes,
Hyperkalemia.
hyperkalemia. So potassium will go high above 5.0. What else? Hyperphosphatemia. Your phosphate levels will go up.
Hyperuricemia.
Hyperuricemia. Good. Your uric acid levels will go up. So you have three things
All
going up,
right.
but only one thing coming down. What is that thing coming down?
Calcium.
Yes, calcium will come down. So hypocalcemia. So with regards to these things, you have remember, whenever you meet things like we are not talking about it into details anyway, but you should know whenever chemotherapy is initiated or chemicals are used to destroy cancerous cells, this is one thing that is likely to happen. Tumor lysis syndrome. Okay. And tumor, when we say tumor, we know tumor, right? Lysis is like distraction. You are destroying something. And syndrome is a group of symptoms. So when you destroy a cancerous cell, what are the group of symptoms that come out or that displays? That's the meaning of, that's an easy way to understand this. Okay. Tumor distraction signs, something like that. In other words, tumor lysis syndrome. So if tumor lysis syndrome sounds big in your ears, it's like tumor distraction signs. What will you see? I'm repeating this again. Don't wait and burn candles on this. Just keep it off head right now so that you can move on. Potassium levels will go up. Remember, we said they affect four main things, right? So potassium levels will go up, mostly above, the normal levels of potassium, 3.5 to 5.0. So when they go up, they can go even as high as 6 point something. So potassium will go up, then phosphorus too will go up. When phosphorus goes up, we call it hyperphosphatemia. Okay, it's like phosphate levels. Hyperphosphatemia. So your phosphorus level will go up. Then your uric acid levels too will go up. So that is what we call hyperuricemia. Okay, uric acid, UA. Then only one thing will come down, which is your calcium. So you have hypocalcemia. Okay, hypocalcemia. So even if you forget anything about tumor lysis syndrome, don't forget about this. Okay. And remember the signs and symptoms they come with. When you have potassium going up, hyperkalemia can affect your your heart. So think of symptoms of hyperkalemia. All right. Arrhythmias, dangerous arrhythmias, which can even cause cardiac arrest. You know that. And when you have phosphate levels too also going up, phosphate levels, both potassium and phosphate levels have a direct effect on how your kidneys function. So these two themselves, and even uric acid, like all of them, but all of them, but these two things are key players in causing acute kidney injury. Okay, you can easily get if not timely intervened. Then you have uric acid also building up. When uric acid builds up, you know what? You can get this it have effects on the kidneys too. Then you can have uremia affecting how your brain even functions because you have uric acid in your blood flows everywhere. It can have a lot of issues on your body. Hypocalcemia, calcium affects how nerves and muscle also function. Okay. And it can also give you dysrhythmias like bad uh, rhythms, heart rhythms. So note them, okay? All right. So at least you know something small about tumor lysis syndrome. If today happens to be your first time of hearing it, we are saying when you give chemotherapy, it can cause bone marrow suppression. Okay. Remember your bone marrow produces all the blood cells that we have. we have three main blood cells, right? White blood cells, red blood cells, and the platelets. Okay, so leukocytes, erythrocytes, and thrombocytes, right? These are the three main cells that are found in the blood. Okay, and they are produced in the bone marrow. Remember, most blood is manufactured in the bone marrow. So when you have chemotherapy, you are saying chemotherapy suppresses the bone marrow. So when you have the bone marrow suppressed, it means you have all of these three components also being suppressed. So when you understand it this way, you will appreciate it. Okay, you have all these three things also being suppressed. When you have white blood cells suppressed, what do you think can happen to the body? What is the function of white blood cells?
Fight infection.
They fight infection. So when you have your ability to fight infection being suppressed, what do you think will happen?
You'll
Septicemia.
be you'll be unable to fight
Your white blood
infection, so
cells will increase.
you'll get
Good.
infections.
You can easily get infections and you will lose your ability to fight some common infections, right? That is why we have to treat these people very special from people who are not undergoing chemotherapy. All right. Now let's look at the red blood cells, the erythrocytes. We know what red blood cells do for the body, right? Red blood cells contains hemoglobin that binds or that carries oxygen to all parts of the body, right? So when you
Yes.
have these red blood cells also being suppressed, what do you think will happen to the body?
Anemic.
Poor
Yes,
oxygenation,
coordination, anemia. So they'll
anemia.
become very weak. You know, I mean, they are eating, but they'll become very weak because there is no oxygen to help with combustion and all of that. Okay, so they'll grow anemic. They'll be, I mean, so in any way that they register it to you, let's say if they give you hemoglobin level of 6 point something or maybe 5, it should tell you that it's red blood cells being suppressed. That is why you have that happening. Okay. And when they are even explaining it in terms of like signs and symptoms, and they tell you the person is weak. Remember, when you have low hemoglobin levels, you can also become weaker. So it could also be as a sign of what reduced red blood cells or suppressed red blood cells. Then the last one here, platelets or thrombocytes. No thrombocyte helps with normal clotting, right? Normal blood clotting. So if you have thrombocytes or platelets also being suppressed, what do you think can happen to the body?
Bleeding.
Yes, the person will have hard time bleeding, or hard time clotting rather. It means the person will bleed a lot, even with just um a finger. A needle stick, a finger stick, right? Something like that. Even to check blood glucose level, you see this person bleeding a lot, right? And that is very abnormal. Okay, so when you have someone undergoing chemotherapy, these are the things that are likely to happen. Okay, when the bone marrow is suppressed, you have all of these things suppressed. So don't think of it as a one-way thing, like happening to only white blood cells or red blood cells or platelets. It's happening to all of them at the same time. So watch out for signs of all of these things when you get questions, not only on one. If you focus on only one, you can be tricked and you are likely to get things wrong. Okay. All right. So now we understand this first part. The bone marrow suppression. What happens? We now know what tumor lysis syndrome is. Even though this slide doesn't contain a lot of things, but we are going to see a lot of things here. So let us pay rapt attention, like we've already begun. So there's also something here. Look at the second bulleted point here. We are saying filgrastim stimulates neutrophil production. So most of the times we give these people this drug, filgrastim. Okay. People undergoing chemotherapy, we give
Yes.
them filgrastim. Do you
Ah,
know what filgrastim? Hmm. Do you know what filgrastim does? So filgrastim is, as it's written here, it stimulates neutrophil production. Let me tell you one thing about this drug. So because the person's white blood cells are suppressed, the person will not have enough white blood cells to fight infections. So we give them this drug to help stimulate like small white blood cells. Okay, grateful. Remember, it's a type of white blood cell which will help the person to be able to fight some infections from time to time. Okay, there is something about this drug. Make sure that when you are giving this drug, you give it um okay, so this is it. You don't give it 24 hours before or after. I think that will make it easy for you to remember. Don't give this drug 24 hours before chemotherapy or after chemotherapy. Okay, so there's also an English thing to also note about this. Don't give this drug before
Yeah, please, why?
or so when you give it before or after um chemotherapy, it's likely to cause so let me say something about this drug before I come back to your why. One thing is that this one is stimulates the bone marrow to produce neutrophils, which is red blood cell. Okay, it's not sorry white blood cell. So it's not used in only chemotherapy, like when even in general neutropenia, when there's a condition or um any disease condition leaves someone neutropenic, this drug can also be given. Okay, so it can be even after radiation exposure or radiotherapy. So this drug itself can give you bone pain. Okay, because it's like it's pressuring your bone marrow. Okay, to produce neutrophils. So one common thing about filgrastim is that you have bone pain. Okay, and most of the times we manage with analgesics to help with the pain. Anyway, okay, yes, and when you give it within this time, it makes the pain very worse. That is one thing about the medication. It makes the pain very, 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 very worse, and you can't afford to do that. Okay, you can't afford to cause severe, that kind of severe sharp pain. So, mostly they want um, they want you to give it. If let's say tomorrow, or let's say today is Friday, right? So let's say if the person will be going for some even do it even have 48 hours before and after. But per English, at least, even if you are late or if you are early, it should be 24 hours before or after. Otherwise, to make when you give it, make the pain very, very, very worse and unbearable. Okay. There might be other reasons too, but this is the
Esther,
commonest one.
please, which drug are you talking about? I'm not getting the drug.
Are you looking at your screen right now?
No,
Phil,
please, I'm driving.
Okay. So filgrastim, that is what we are talking about.
Okay, so
That-
thank you.
Okay. So I'm circling it right now. Okay, filgrastim. All right. Have I answered you? The one who was asking the question, the why? Any other
Yes.
question before we carry
Yes,
on?
sir.
You said
Thank you. Thank
the
you.
pain will increase.
Okay.
The
Any other
brain
question before we carry on? So take notes, okay? So when they ask you, maybe you are giving maybe filgrastim and they ask you maybe they tell you the person is in pain or something. Remember, pain is just a common thing that will happen. Okay. Yes, it's a common thing that will happen with filgrastim. Please, if you don't see filgrastim on your ankles and you see any other thing, so upon request, I'm preparing something on pharmacology. I don't know when I'll finish, but I want to make it very simple as much as we can. Okay, we can't do everything, but at least the basics so that we can understand a lot of things. Look at this one, the suffix. If you see any drug that have maybe grastim, 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 ending in grastim, and it's not filgrastim, please, it is the same. Even if you don't know, take it to be the same drug as filgrastim, and answer your questions accordingly. Let me give you an example. Like we have another drug we call peg filgrastim. So you have PEG, okay, like PEG attached to this one. So like peg filgrastim, okay. Yes. So if you have any drug that ends with, grastim, take it to be like filgrastim, okay, something like that. So it is like if you have lisinopril, you know about lisinopril, and you don't know about enalapril, and you go to the English and you find something like enalapril. Does it mean that you can't solve questions on enalapril? You should be able to solve. If you know about metoprolol, then you've never heard about bisoprolol or maybe any other um, form of beta blocker, but it ends in law. You should know that this is a beta blocker we are talking about, so you should be able to make application. So take note of those things. Okay, you learn one. The things are plenty. You can't learn them individually. So you learn one, then you can apply carefully. Okay, let me use the word carefully. You can apply carefully to solve other questions. All right. Then what else can we talk about? So, like I said, filgrastim, bone pain is very common. Okay, you manage it with analgesics. Okay, and because it simulates neutrophil production or white blood cell production, you can have white blood cell count also becoming a bit higher. Okay, which is not too high. Not too high that we can consider abnormal. Okay, all right, and what else? What else? I'm thinking of something else to add. All right. So with regards to, okay, so let me come back to this one. White blood cells, red blood cells, and platelets. We said you have all of these things being separate, right? When you have reduced red blood cells, what can we do to help the person?
Transfusion.
Yes,
Blood transfusion.
blood transfusion, or if they can't receive
equate,
blood,
Tablet.
equating,
if they can't
equate.
receive blood, yes, you can give epoetin alpha.
Okay.
Okay, epoetin alpha, EPO. I don't know if this thing can let me write EPOE. So OE, okay, epoetin alpha, epoetin. And the alpha is ALFA, like alpha. So if the person, because of religion or a special concern, can't receive blood and blood products, you can use epoetin alpha. Okay. All right. So that's how to take off reduced red blood cells. And remember I told you they will have fatigue and they will have dyspnea too. You know that because red blood cells can carry oxygen, they carry oxygen around the body. So they will be dyspneic and they will have pallor. So they are all symptoms associated to red blood cell production. Now let's see. When you have thrombocytes or platelets coming down, remember we all said the person will have risk of bleed, right? Now my question is, how do we help manage these people? In terms of toothbrush, what kind of toothbrush should we advise them to use?
Soft.
A soft
Soft
toothbrush.
bristle.
If they want to trim, what kind of trimmer should they use?
Electric.
Electronic.
An
Nail clip.
electric.
Nail
Good,
clipper.
good. They should use nail clipper when they want to trim their when they want to cut their fingernails. Okay, they can't use just blade or something different, and they can't if you see any option that says they want to cut the edge of their fingernails, it's a trap. Okay, the corners, because they can cut themselves and they can cut themselves and cause bleed. Okay, so they have to cut their nails straight. So take note of that. And I think it's also that intervention also applies for people with diabetic foot, okay, or maybe or diabetes. You remember? So you use the same way too, because we don't want to cut them, right? And so we are saying we have to use electric razor for them, right? All right. Can we give them iron injections?
No.
No.
So
No.
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 So take note, it's also a trap, okay? No matter how good that thing sounds, okay, no matter how good that option will sound, if they are going to take a medication and it's iron intramuscular, please don't give it. They'll bleed into the tissues. So no IM injections. Okay. And what kind of drugs, like oral drugs, should they avoid?
Okay.
Antiplatelet.
Anticoagulants.
Heparin,
Ah,
Anticoagulants.
warfarin.
Good, good,
yes.
good, good. So you know what you are talking about. That is fine. Okay. Now at this point, if you have any question, you can ask. So if you have any question, you can ask. So we've talked about um platelets. We talked about white blood cells, right? Have we talked about white blood cells? We talked about red blood cells, what they do, right? And thrombocytes or platelets, what they do, or how we can help. Yeah. No, I think we've not talked about white blood cells. Okay, so now let us look at something. Let me talk about white blood cells in a bit. Aduma, your hand is up.
Yes, please, thank you. Please, I would want to you to give, if possible, give an example of how term can be stated in the question.
Okay, so you want to know how, like, you want a question on Philgrastim, right? That's your question.
Yes, please,
How
how it
they
can
can
be stated.
help you. Okay. All right.
Yeah.
Let's see if I can pull out anything like that before we carry on. But let us talk about this one before I come to that. Okay. I'll surely give you one. Let's look at this one. We've talked about um this one, right? Thrombocytes that they cause bleeding. We should use soft, how do we call it? Soft brushes and all of that. This one, red blood cells, they can cause anemia. So if um hemoglobin is below 7, you can transfuse or give people eating alpha. Now, white blood cells. Who can tell me how to manage neutropenia in chemotherapy patients? Neutropenia.
Isolation. Isolation.
Are you sure? Do we isolate people who are infected or
Reverse
people
isolation.
who are who are let's say who have
Reverse,
risk of
reverse
getting.
isolation, reverse
Reverse
isolation.
Exactly.
isolation. Reverse, sorry.
Yeah,
Reverse.
so be careful. Okay. and and with the reverse isolation, who can give us characteristic of things that should be in the room? Like
They
how
Positive
need
air
to
pressure room.
avoid
let us make it one after
Positive.
the other. If you
they
want to
need
talk,
to
kindly raise up
avoid
your hand.
flowers.
Kindly raise up your hand and talk so that you don't have a lot of people coming in all together. Yes, who wants to try? Philomena, let us hear from you.
So with the neutrophil precautions, so we avoid flowers in their room.
Okay.
We also wash the fruit and vegetables very well,
Mm-hmm.
or you can pre-cook it to
Okay.
avoid any bacteria. And then we also encourage them to avoid overcrowded areas.
Okay.
Um, yeah, that's what I remember.
Okay. Any other person? Okay. All right.
Sir, please.
What?
I
You didn't raise up your hand. Okay. Yes. Let us hear you. Oh, you can talk. Oh. Okay. You not talk again, eh? All right. Let's carry on then. So let me ask my question. What kind of pressure should we keep in that room? Is it positive or negative pressure?
please positive pressure.
Negative pressure.
Positive pressure. So the same as the pressure kept in theater rooms, right? The same as that
Yes,
pressure.
please.
Yes, so
Yes,
take note.
please.
All right. So what can we say about standing waters in their room?
They
Do you have
shouldn't
any
It's not
do,
allowed.
yes,
that
do you have any nurse here um working with chemo group or at chemo ward? I know we have some here, but they will not own up. They will not show up right now. Right. Yeah, so no standing waters, okay? No standing waters. Most of the times, even for bottle of water, it is it is um it is noted that when they drink and let's say if you have 500 mils of bottled water and they drink to about half of it, well they can't leave it there and drink it after some hours. It has to be discarded. Okay. So standing waters, whichever, whether in barrel or even the water that you drink. Okay. And all of that. Yes, what else can we say about them? Do we leave the room open or closed? I mean their doors.
Close.
Closed.
Hello?
Okay. Good. Mr. Regina, behind us up.
Yes, please.
So,
So if you were saying that the water should not be left for some hours. So how many hours?
Okay, so I can't say the number of
24
hours,
hours.
but listen, when they as soon as they give you the option that the water is left even for 1 hour, like they will tell you if they can reuse a water that they drank some before. Okay. If you see anything like that, it's a no-go area. Even if it's 1 hour, 2 hours, 3 hours, it's a no-go area. They can't do that. Okay. So anything that has been left, especially any water that has been left standing for some time,
Okay, thank you.
it's not encouraged. Yes. because we want to prevent them from infection as much as possible. That's the reason. Okay, that is the reason. Okay, let us continue with what we have here. So we are
Sir,
saying
please, sorry. I missed something. Please, you said the reason for something.
the reason for what for something.
I that part. I heard you saying that is the reason.
Uh, we are someone asked about why we shouldn't leave standing waters in the rooms of people who are neutropenic. Okay, and we are saying just to prevent infection.
Okay.
Okay, yes, to prevent infection as much as possible. Doesn't matter the number of hours. If the question tells you that it's been standing, no matter the hours, please don't give it to them again.
Okay.
Yes.
Okay.
All right. So one thing that we have to know is that we have something we call um absolute neutrophil count, ANC. It's in our notes. Those of you who have seen it before, ANC, absolute neutrophil count. To be able to consider someone as neutropenic or to institute these neutropenic precautions for such person, the person should have absolute neutrophil count of less than 500. Okay, less than 500. So if you see anything, even 500 inclusive, if you see 500 or less, absolute neutrophil count, please consider the person. It's an emergency. Okay, the person is considered to be severe neutropenic, and temperatures can rise above 38 or so. So what you have to do is that you have to institute all those precautions we just talked about, protective precautions. Okay, like our brother said, no fresh flowers, no standing waters. They have to be kept in a private room. Okay, it's a medical emergency, private reverse isolation room. Then remember, no fruit or no raw fruits or vegetables. Are you there? No raw fruits or vegetables too. Okay, no raw fruits or vegetables. I've repeated it right. So take note of that. I think we've consumed everything that we have to say here. You know, some common signs or issues that come with chemotherapy, right? Um, alopecia. They tend to have temporal, how do you call it? Hair loss, right? They have temporal hair loss. When it comes to GI symptoms, nausea and vomiting is very common, and they also have mucositis. Some time ago, I asked someone what's mucositis. The person said mucositis is inflammation of the mucous membrane. Okay, but mucositis is the mouth. It has to do with the mouth, not mucous membrane. Okay, inflammation of the mouth. So when you get questions and they tell you that maybe to help prevent mucositis or to help ease anorexia among chemotherapy patients, rinse um, the patient's mouth with a commercial mouthwash to soothe the mouth. So they'll polish that option in a way that will sound nice in your ears. Okay. Any commercial mouthwash is discouraged because they contain alcohol. So in other cases, or what I'm trying to say is that avoid alcohol-based mouthwash. They will not tell you alcohol-based mouthwash. They'll tell you a commercial mouthwash. About 99.99% of commercial mouthwash they contain alcohol. So when you see that in the question, it's a no-go area for people with mucositis under chemotherapy. Are we there? Then what else can we talk about? Like side effects of this thing. Yeah, so there is something that Yeah, I just remembered. There's something that I have to let you know. We have some chemotherapy drugs which are very, 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 very how should I even like they can cause serious necrosis. They are called vesicants. Okay, vesicants. Vesicants. They are very, 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 very dangerous, especially when they cause like when they leak into the skin. Okay,
Can you
like
spell it again,
extravasation.
please, sir?
That is extravasation, right? Is someone talking to us?
Yes, I said, can you please spell it, please?
Oh, okay. Okay. The extravasation. Which one? Is it extravasation?
The vesicant. She's
Vesicant.
asking for the
Oh,
spelling of
vesicant. Okay.
vesicant.
VE. Okay, let me spell it. V. Extravasation we can spell, right? Extravasation. S-E, my mouse. So this is extravasation. Sorry, I hope you can see. Then the vesicant is, let me write it down here. V E. Let me try this mouse. Let me see if it will. Vesicant. So T. Okay. So this is the vesicant you're talking about. If they are plural, you add S. Okay, vesicant. So when we say vesicant, it's like they are very dangerous to the tissues if extravasation happens. Extravasation is leaking of um, drugs into tissues, okay, from your IV lines into, or from your intravenous, let's say from veins into tissues, yes. So that is extravasation. You know, we have chemotherapy drugs like vincristine. You've seen them before, and they are very common drugs on the ankles. Okay, Vin Crest, Vin C-R, Vincrestin, INE. Okay, when you add E, Vincrestin. So this I, Vincrestin.
Vim
Okay, and
blasting.
okay, you call it Vincrestin. Okay, whichever, Vincrestin or Vincrestin. But that is the spelling down there. Okay, so this drug. And there's another one known as doxorubicin, yeah, something like that. So if you see any chemotherapy drug, if they tell you it's chemotherapy drug and it ends in Crestin, whether vincristine or anything Crestin, that is also how you can know that it's a drug for chemotherapy. Okay, and I think most of them to end in the ribosine. Okay, that's an example is the doxorubicin. Should I write this thing? So let me spell that one. Like, or okay, Doxo, 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 right? Doxo. Then Rubicin, Rubi. So how would you pronounce this one too? Oh, this one is Doxorubicin, exactly as I said, right? So Doxorubicin. Okay. So Doxorubicin and Vincristin, please, you see them some time ahead of you. Chemotherapy drugs you shouldn't forget. Okay. These are examples of vesicants, like they can sorry, they can cause serious issue when they leak into vessels. Do you know that sometimes some of these issues can even lead to amputations in serious cases. They can cause tissue necrosis in a way that the arm can never be saved or can no more be saved. So when you see any extravasation, when giving any of these vesicants, what do you have to do first? Who can tell us what do you have to do first?
Stop medication.
Stop it.
You stop the medication.
You stop the medication. Seriously, like that's the first thing to
Medication.
do. Okay. Do you remove the needle?
No, you won't remove the needle. You try to withdraw some of the medication from the vein.
Very good. Please take note of this very, very well. It's a hotspot English trick. Sometimes when you see a leakage like in normal thing, I mean in normal or other drugs, it's like stop it and if you can remove it and something like that. Please, this one, when you stop it, don't remove the needle. If you get any option that says remove the needle or remove the IV port or something, it's a trick. It's a wrong answer. Don't remove it. But exactly as our sister said, if there's a chance of aspirating or withdrawing some of the drug from there, just do it around that time. You can have some blood, I mean, in it and everything, but try and withdraw as much as you can. Aspirate the drug. And you do that before I mean, because you don't have time, if you don't do that, the body will keep on absorbing. Any minute that you wait, the body, whether tissues or whichever, the body will still, I mean, to keep on absorbing the drug, even in the tissues, the more time you wait. So, when you are prioritizing them, when you have extravasation of any of these vesicants, first thing, stop it. The next thing to do is make sure that you keep the needle or the IV port in place, and withdraw as much as you can, aspirate the drug as much as you can. After you've done that, then you can call the doctor. So you don't stop and call the doctor right away. You stop the drug and do all these things we talked about before you call the doctor. Okay. Do you have to flash the line?
No.
No.
So that one too is a no-go area. Don't flash the line. So it is like when you have blood, let's say agglutination happening, or let's say um, mismatched blood, right? You have blood reaction happening, and you stop the transfusion. You don't have to flash the blood too. You know that the more you flash, they'll polish the wrong answer for you. Please don't flash whichever thing you have left in there into the body. You worsen things, okay? All right. And whenever you are handling all these chemotherapy drugs, you know that you have to wear gloves, and most of the times they are allowed to, or they are
I'm sorry.
encouraged to flush their home toilets,
Hello, sir.
like someone talking to us.
Sorry. Please, I would want you to repeat about the blood flashing, transfusing blood and flashing again, because I didn't get it well.
So I made a referred example that if you are, let's say, giving blood and there's a reaction, it is the same thing. Like when you stop the blood, you don't flush the line. That is what I said. I hope that one we all know. I just said it, and that is true. You don't flush.
Please,
Mhm.
how is that different from them saying that when the patient has transfusion, you stop and you start running a normal saline? Is it different or it's a wrong thing to do?
When a person has a blood reaction, you stop and you run normal saline. Who can answer that question? Oh,
Please,
we should
you didn't say
we
No, you
shouldn't take
stop it.
run
we
normal.
shouldn't take
You
time.
didn't say we
Uh-huh.
run normal saline.
No, you
It's
stop it, but you
when
don't run
when
normal
when you
saline.
just stop it, you don't run normal saline because it's like you are pushing this one further.
The remaining blood in there.
Yes, please, you are pushing it further, so you don't run saline.
Okay. Um, please, do you get it? Even if you run a saline, look out for options that says you change all tubings completely before you run. Are we there?
Yes, sir.
Yes. So if you
What
try,
is
if you,
thank
Repeat
you.
what you said, please.
so I'm saying if you suspect, let's say, a reaction, blood transfusion reaction, you know that tubing, they normally use the white tubing. Okay. Most of the times, things that are here is what is being projected on the enclave. Okay. You see that white tubing, one side containing it's connected to normal cell line, mostly 250 mils of saline bag, and you have blood to going. So when you suspect a reaction, you stop it and you take the whole tubing and the document or the paper it came with, okay, the the cross match or whichever, and it came with, um you take it to the lab, you send it to the lab, okay, but you don't run saline, like you don't run the saline to flush the rest of the blood into the patient. And even if so, if you get any option that says it clearly that change tubings and run normal saline, that could be a correct answer. Okay. But just run saline, it means you still have that tubing in there, which means that you are pushing the rest of the blood in the in the tube. I mean, in the tubing, you are pushing the rest of the blood in the tubing into the patient, which will further worsen things.
Yeah,
Okay.
please, my line went off. I didn't get you about the normal line. Thank you.
Okay. Okay. I'm repeating the whole thing again. So what I'm saying is that if you have a transition reaction, okay, and the question says that, I mean, transition reaction, you have to stop the transfusion. We all know about that. And you have to give normal saline. We are saying you will not give, I mean, you will not open the normal saline to flush the rest of the blood in the tubings into the patient because um, it will worsen the reaction. Okay. Yes. All you have to do is that you will have to disconnect or yes change the tubings with the blood. You know, when reaction happens you have to send the tubings and the blood um to the lab, okay, for them to carry on with their own further investigation or whichever. Okay, so if you still have to hydrate patients after disconnecting the main tubing that is connected to the IV line on the patient, then you can run your normal C line. Please, do you all
Please,
understand it?
to be clear, the tubing you are talking about, are you talking about the giving sets?
Yes. Giving set
Yes.
are called tubings, IV tubings.
Okay, you disconnect it, but you can use a new given set to give
Use
normal
a
set.
new one, yes. You
Okay.
can't say you can't you will not hydrate, you will never hydrate the patient again. Okay, but the tubing you used, even though it has saline connected, but you will not use that one, you will disconnect it from the patient and add it to the blood and send it to the lab. But you use a different IV tubing or a given set altogether if you have to hydrate the patient again. Are we clear on that one?
Okay, thank you, sir. Yeah, we are
What
clear.
You're
about the
welcome.
needle
Foster,
itself, sir?
you've heard what's up. Foster's hand was up first.
Please, you've clarified.
Oh,
Thank you.
okay. Okay.
Yeah.
Yes. Any other question?
Bosgia, what
Yes.
about the needle itself?
The needle.
Yes, we've talked about the giving set, but what about the needle itself that goes into the patient?
There is no
Because,
needle. It's
Needle.
rubber. It's
okay,
rubber. The
yes,
IV line.
yes. What about the
That
cannula? Yes, the cannula. What
you,
about
you,
it?
you can take
You
if you take
remove
the cannula
everything.
out. Wait, wait,
You
even
remove
if you take
everything.
hello, are you there?
I'm here.
No,
If
no,
you
you don't remember.
if you take the cannula out, how will you hydrate the patient?
Well, okay. Okay.
That's the reason, right? The
Mm,
cannula is the connection between the patient blood and the cannula. I mean, the part of the cannula that is out is very, very small, just a small distance.
okay.
Okay.
Okay, then that answers my question. Thank you.
So it's like a continuation of the vein. So you can't remove when
Thank
you
you.
remove that, and if you happen to get a very difficult vein, I mean a difficult person to find vein for it, you're going to worsen the situation because the person will need some maybe IV drugs or things like let's say hydrocortisone or dexamethasone, anything that can help reduce the reaction. So how are you going to give all those medications if you receive orders from the healthcare provider? So you remove up to the IV tube and you don't remove the cannula. Any other question on this one?
Thank you, sir.
Yes, but Sima, please, me, I'm confused about something. The vesicant thing you were saying, I didn't get it well. You said
Okay,
when I hear explain the whole thing again.
so so I was explaining vesicant and I just used blood transfusion as an example to I mean to talk about something. I think I used to talk about the I mean the flashing pattern, all of that, right? And and we had a lot of people asking questions about the blood transfusion. So let us raise that side. Okay, we are talking about chemotherapy. Now back to our vesicant. We are saying vesicants when they cause vesicants are drugs, okay, for chemotherapy that are very dangerous. Should they cause or should extravasation happen? Let me give you another drug as an example. Noradrenaline or norepinephrine. Those of you who work in the ICU here, when they extravasate into tissues, they are very dangerous. They can also cause necrosis. So most of the times, it's either you have a peripheral line that is easy for you to notice if extravasation is happening, so that you can disconnect it as quick as possible, or you have a central line, but you can't use it in. We have some lines that I mean, we call they are not they are not central lines, but they are called mid lines. Like you get them from deeper veins. Okay, we discourage giving drugs like that in deeper veins, which are not central lines, because when extravasation happens, before you see or before it comes out for you to see, you have a lot of things. I mean, lots of the drug already poured into the tissues, and you will not like it. It can cause it. In serious cases, it can even lead to amputation. So I'm just giving you all these different examples for you to know how vesicants can be and how dangerous they can be. Okay. So we are talking about vesicants, like as in chemotherapy. We mentioned two drugs. Doxorubicin. Okay, doxorubicin. Yeah, DOXORUBICIN. Doxorubicin. And vincristine. Someone said vincristine. Anyhow you pronounce it. Okay, these two drugs are examples of vesicants. When you are giving them, and let's say extravasation happens, what we are saying is that extravasation is when you have some of the drug leaking into tissues. You can have tissue necrosis. Means your tissue will rot. It will die and it will rot. Okay, I mean it will die and with time. I mean rot is extreme, but it will die. I mean it kills your tissues. Okay. And we want to prevent that. So we are saying when you are giving and you find any sign of what tissue necrosis, sorry, extravasation, first thing you stop the drug. And we are saying you don't flash, you don't remove the IV cannula in situ, you don't remove it. But what you do to help the situation is that you rather try to aspirate. Okay, you rather try to aspirate and see if you can remove most of the drug. Okay, if you can remove most of the drug from the IV site. That is what we just said. Are we all? Is it understandable now?
Yes, please. Yes, I get it now.
Yes,
Thank
sir.
Okay. All right. So I think everything I can say about this is what I've said. If you have any contribution on this one. Okay, so let me say one last thing here so that you can repeat it. One difference between we are not doing radiotherapy here, so but I just want us to compare the difference between chemotherapy and radiotherapy. Chemotherapy is like because you are given a drug, it will be absorbed systemically, right? So it has a systemic effect. Chemotherapy has systemic effect. When you're doing radiotherapy, you are exposing that area where you have the cancer to targeted therapeutic high waves or high rays. Yeah, it's high rays. Okay, radiations. So it's like it's local. Okay, it has a local effect because it's only that affected part that gets exposed. But with chemotherapy, you have your whole body exposed because the drug is absorbed systemically. So that is one thing you should know about the differences. Okay. And one thing too about both of them can cause pancytopenia, right? Regina, I'm coming. Sorry, Regina. Both of them can cause pancytopenia. But please, if you get let's say NGN question like case study question, like the grade one, the one that you have to select, this one affects this one affects this one. Pancytopenia is likely to happen more in chemotherapy than radiotherapy because of the systemic effect of chemotherapy. Okay. Radiotherapy, it is only that affected parts exposed to the rays that get affected. It doesn't mean they can't get, but it doesn't normally happen as compared to chemotherapy. We've said a lot, haven't we, on this small slide? Sister Regina,
Yes, but yeah. Please, I just wanted to find a week of why are we giving the Vasacans?
Sister Regina, you left class, right?
Yes, please.
Let's continue. This one day I'll not go back, otherwise we'll not finish. Sorry. But maybe you can play the recording, okay? Otherwise, I'll continue. We just give an example of chemotherapy drugs. We call them vesicants, okay? So they are vesicants because they can cause tissue necrosis when extravasation happens.
Oh, okay. Okay. Thank you.
Next time, stay in class. Okay, let's carry on. So someone has a question about filgrastim. I think I have a question here. Okay, let's see if I didn't put a question here on filgrastim. I'm going to ask you. Okay, I'll pull one out and ask you in live class. So I haven't forgotten. Okay, the one who asked the question. So you are saying chemotherapy drugs destroy rapidly dividing cells. Cancer cells are how you can appreciate these things. Like when we say cancer is like a cell that's like is growing on its own without any check. Okay, every cell, living cell, cell is the basic unit of life. I hope we all know, right? Every living cell in us have a way and a controlled way of growing, how they should operate and what should happen from time to time. But cancerous cells, they are doing their own thing at different times. Nothing controls them. That is why they become cancerous. or that's why we call them cancerous. Okay. So we have these drugs that destroy them. And we are saying, I give the drug, even though the main thing is to destroy cancerous cells, but they affect bone marrow too. They affect the GI tract. They affect hair follicles. They can even affect reproduction. Okay. So there's so I think I forgot to add this one. When you are being treated on chemotherapy, I think you should use a condom. It's also part of the thing. My chemo nurses, are you here? Why are you not talking? Yes. So it's part of it. You have to use a condom. Okay. That is if only you have the strength. Use a condom. All right. Let's continue.
So,
Yeah.
so come again.
Are you a chemo nurse? Are you a chemo nurse?
Oh, no. I had condom. I'm wondering what.
So I'm saying use condom. Okay. When you are undergoing chemotherapy.
Why?
Who can tell us why?
I think maybe because they are prone to
Because of
infection.
the risk of infection.
Okay.
Um, Hello, please. I think body fluid come.
Is the person talking to us?
Yes, please.
Uh-huh, yeah. So talk and
Their
let us hear you well. Uh-huh.
their the chemotherapy, the drugs affect their body fluids. So
Mm-hmm.
let me say it becomes how do I put it? Is it should I say toxic? So you need to um wear condom
Okay.
up.
Okay. I think your answer is so it's like uh it's I mean the effect is both sides, okay, but what you are saying is the main answer. Also to protect the person under chemotherapy from infection, certain infections. But the main thing is to prevent what harmful exposure of toxics, of like toxic chemicals that when you're undergoing chemotherapy, like we said, the whole body is exposed systemically, right, to the drug. I was about saying something before someone asked the question. Even with like flashing of toilets, okay, some of the drugs you have to flush your toilet about twice. Okay, whenever you use the washroom, okay, you have to flush it about twice.
Is it not twice?
How again?
Is it not 3 times rather?
Is it twice or three times? Radiotherapy is different, but I think chemotherapy too is also different. We talk about radiotherapy different, maybe some other time. I think it's twice. Who can confirm that for us? I think it's twice. Someone should confirm it for us right now. Encles, how many times to flush the toilet when undergoing chemotherapy, not radiotherapy? Who is telling us? Okay. If no one, then
More than three
uh,
times.
is it three times?
Please, it's twice. I just want to confirm.
It's twice. It's
It's
twice.
twice. Yes.
Yeah.
So it's twice, yeah. So I think I remembered it correctly. So it's twice. Okay. Radiotherapy is different. We'll talk about radiotherapy. Radiotherapy, we have one that you keep the radioactive element within the patient. We have one that is like external, right? And how to manage them. We'll talk about radiotherapy later. But for chemotherapy, it's also different. So chemotherapy is twice, okay? So was it Franklin who asked the question?
Yes.
Yeah, so chemotherapy is twice. Okay, thank you for researching. Okay, today we've done well. So the question that our sister asked, okay, the condom is to prevent you from exposing your partner with like some of the toxins, okay, or the harmful secretions, because the drug affects your secretions too, so that you don't end up transferring. So it will be like you also in a different way, you also be treating your partner with chemotherapy drug, like in some way. That's what it means, okay, and which could be harmful to your partner. That's why you have to use a condom. And for you to, it helps protect you from some infections that are possible for you to get. I mean, STIs, right? Okay. I think that is all. Let us look at some few questions here, then see how we can solve them. Risi, do you want to answer or read? Risi, your hand is up. Okay. Who wants to read for us? Risi. Okay.
So I just want to find out about the condom because I read
Uh-huh.
somewhere that um, when most women are on chemotherapy, they are being advised to, stay away from sexual activities or wear condom, as you said, as a result of, trying to avoid pregnancies because the chemotherapy sometimes affects the seeds, as in um the pregnancies. So in order to be safe and keep your child safe, you have to
Good.
avoid
Good. Good.
like
Thank
the
you.
best.
Thank you. It's also part of the reason. Good. So to prevent birth defects,
Yeah.
yes. Thank you for bringing that up. So birth defects, exposure of chemicals, like harmful chemicals to your partner, then some infections. Yes. So three in one is true. Thank you. Thank you for bringing that up. Okay. So who wants to read this one for us?
A
Yes. Let us go.
client
Anyone?
7 days post chemotherapy calls the oncology clinic. Which statement requires immediate action? 1. I feel very tired and weak. 2. My temperature is 100.8 degrees Fahrenheit. That is 38.2 degrees Celsius. 3. My hair is starting to fall out. 4. Food tastes metallic.
So what's the answer?
Sir, please, I think the answer is 2.
100.8.
2. My
The
temperature
answer is
is
two. So infection takes what? The maximum or the highest priority. Okay, it's very very important. So that is your rationale before you. What is this Nadel? I don't know whether I'm pronouncing it well. Is it Nadel period? When you say Nadel period, what does it mean?
The period of the when WBC is very, very low.
Very low.
That
Good,
occurs
good.
7 days
So
after
when
chemo.
good. So it normally happens between seven. Some will say 7 to 10. Some will say 7 to 14. So others will also say 1 week to 2 weeks. Okay. So that is where you have it's a point where you have the chemotherapy suppressing both your white blood cell, red blood cells, and platelet count to their lowest point. So that's the nadir period. So when you hear of this pain anywhere, that's what it means. Okay. Okay. All
Boss,
right.
can you
And
please show the question? Sorry, some of us
okay.
missed. Hmm. Okay, thank you.
You're welcome. So let us take note of it. It's very important. The rest are just common signs and symptoms that come with it. Okay. The next one. Which interventions are appropriate for a client with chemotherapy-induced thrombocytopenia? Let's do this one together because it's like select all that apply. So it's appropriate, okay? It's appropriate for a client with chemotherapy-induced thrombocytopenia. Is the first one correct?
Yes.
1, 2, 4.
1, 2.
Second one, is it correct?
Yeah.
Hmm?
Yeah. The
Yes.
second one is
1,
correct.
2,
Some people are
4.
hiding. Some people are hiding behind people, though. Option
Oh,
3, is it
no.
correct?
It's wrong.
No.
It's wrong.
No.
To boost appetite, are you sure? They don't eat
No.
well.
Flossing.
Flossing will cause
Bleeding.
bleeding.
1,
Good.
2, 4.
Good. So you see, even though the later part looks more promising, but the first aspect makes the whole thing wrong.
Mm.
I hope you get it.
Yeah.
Yeah.
Okay. Option 4.
Yeah.
Correct.
Yes.
Option
Correct.
5.
No.
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 Why?
Wrong.
It's going to cause bleeding.
It's going to cause them to bleed more.
Yeah. 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 So that is answer 124. That's 124. Yeah. Should you get similar questions like this on the NCLEX? How is it going to be? So
Good.
I have another one here in the form of prioritization. You know, we just did prioritization not long ago. Who wants to read for us? Which client should the nurse see
Which
first?
line? Okay.
I've read it myself. Yes. Who wants to try?
Me, the next first one. Chemo client with platelet count 90,000. 2. Chemo client reporting nausea. 3. Chemo client with C100 and sore throat. 4. Chemo client with hair loss. I'll go for 3.
Are you sure it's 3?
I don't hear crowd. No,
Are we sure it's 3?
Yeah,
it's 3.
because it's way below the normal range for the white blood cell.
Okay. Some people are still not sure. They're searching for different answer. Where did I put this
Yes.
one?
Yeah.
Oh, yes, so it is 3, okay.
Yes.
I think
What's
I
wrong?
lost the question. Shit. Sorry, I lost the question.
Hey.
I lost the question anyway. So, yes, the answer is 3. Okay. I was supposed to bring a question here. I have the answer here, but the question is not here. Anyway, no problem. Let's take this question. Which lab value is most
So
concerning in the
you
chemotherapy?
didn't show the answer of the first one, or you can with
Yeah,
the
the answer
rationale.
is 3, like you said. The answer
It's
is
three,
3.
but it's missing. The rationale is missing.
Okay, the answer is 3. So,
So which love
who can help
most
us with this one?
which love value most concerning in chemotherapy client? 1. Age, hemoglobin of 10, platelet of 150,000, and then ANC 400, and then WBC of 5,000. I mean, you just said the value, anytime the ANC is below 500, it's a red flag. So I'll go for 3.
Yes,
Mm-hmm.
the answer is 3.
Mm-hmm.
Okay, let's look at this one.
Please, can you go back to the previous question?
Are you okay?
Yes.
Okay.
Can I also see the rationale for the last two questions, please? Thank you. All right,
So,
thank you.
for this question, you won't even spend about 30 seconds on it if you listen to the discussions we had. Okay.
He said, but
Uh,
if you don't know, not get them. If you don't know the ranges, I was asking for the rationales. Maybe they'll put the ranges there because we
oh,
don't
This
have.
one is if you
oh
know, you
yeah,
know.
yeah, yeah. This one is like if you know, you know. You know,
Yes.
hemoglobin value of below 7.0 is what is dangerous. Okay, most of the times, and it's I think most of the time if it's below 7, that is where most healthcare providers require you to transfuse. If it's less than 7.0, you know, platelet count is between 150,000 to what?
400,000.
450,000.
Yeah, so this one is not an issue, right? White blood cells between
5,000
5,000 to
to
10,000.
10,000.
Some will say 4,000 to 11,000. That's the wider gap. That is also normal. Okay. This is the abnormal.
So the platelet is between 150 to 450.
Yes.
Yes, 1,000.
1,000. And the ANC is what?
150,000. No. Hey, please, there's 1,000
Yes,
attached though.
yes.
Not just
Yes.
150. Okay.
And the,
150,000 to
and the ANC is what?
this is just 400. Like if you have it led, so it should be more than 500.
Okay.
If you have it anywhere below even 500 or below, just watch it.
NWBC. NWBC.
WBC is what we talked about right now, 5,000 to 10,000. Most labs will give you, but when you
Okay.
see some labs, you see 4,000 to 11,000, like
Okay.
1,000 back and 1,000 added. Okay, like
Okay.
that's 1,000 minus 1,000, which is still
Okay.
normal.
Thank you.
Yeah. So let's see what we have here.
Selma,
Yeah, so
please.
that is the answer. Yes.
Selma, please, sorry. Please, can I see the last two questions? The one that we missed the rationale.
Is it this one?
No, the one before
Yeah,
this
this one.
one. Yeah, this one. Okay, thank you.
Yeah, welcome. Let's solve this one too quickly. You see. Just give me some few additional minutes. Okay, we'll finish right now so that we can go. Someone should take this one for us.
A
Okay.
client with platelets 18,000 has which finding requiring immediate intervention? 1.
Okay.
Petecia. 2. Epistasis. 3. Hematuria. 4. Fatigue.
Okay. So you see, all of them are issues with bleeding, right? They can be issues with bleeding. So which one will be the priority?
Yeah, I'll go for one. Petechiae.
Okay.
Bleeding under the skin, yeah.
I'll
Hematuria. I'll go for hematuria.
You
I'll
want to
go
go
for,
for the material?
yeah. I'll go for 3 because that, indicates probably might be an internal bleeding somewhere because
Okay.
the blood
I
is
like
coming.
I like that term you said,
I'll go for
internal
3.
bleeding. Yes. Isn't that interesting?
Yeah. Very, very.
Isn't that interesting? Can we go on?
Yes, it's very interesting.
Yeah, very interesting. So let's take this one too. Fast. Who's reading? So
The
I think
next
Very
your finger is still posting. Your is here. Okay. Should I read myself or okay?
The
Then
nurse is preparing
let's
to give filgrastim. Should it be administered? 1, 2 hours before chemotherapy. 2, 12 hours after chemotherapy. 3, 24 hours after chemotherapy. 4, immediately before infusion.
What's the answer to this?
24
24
hours.
hours.
24
Yes.
hours.
We talked about this, right? Not long
Mm-hmm.
Yeah.
ago.
Mm-hmm.
Okay. Yeah, so let me add one question or maybe two questions on field team so that we call it a day for today. And the next time we come, maybe tomorrow, yeah, we shall pick it up from here. It's my prayer that maybe tomorrow we finish with this topic. We love it. This one and some few others. All right. So my next question on field team is this. Um, are you there? So the
Yes,
question
please.
is a client receiving filgrastim has a white blood count of 52,000. What is the next best action? A client receiving filgrastim has white blood cell count of 52,000. What is the next best action? 1, continue medication. 2, hold the dose and notify provider. 3, administer next dose early. 4, document as normal response.
All the dose and
So the question, please, what is the question?
Hello.
I said I'm reading the question. I didn't
question
submit
again,
it.
please. Question again, please.
So listen attentively. A client receiving filgrastim has a white blood count of 52,000. Are we there? What is the nurse's best action? 1, continue medication. 2, hold the dose and notify provider. 3, administer next dose early. 4, document as normal response.
2,
Hold the door.
hold the dose and inform the provider.
Yes, that is correct. Who knows what is happening?
Leukocytosis.
Leukocytosis. Good. You have lot of white blood cells being produced, like immature white blood cells. Okay, and do you know that that can increase the viscosity of the blood and can increase thrombotic effects? Are you aware?
Mm-hmm. Yes,
Yes. Yes. So when it will make the blood very thick. Okay, that's what it means. When we say hyperviscosity, when you have
I've logged it.
cells, yeah, becoming plenty than it should be, it will make
Mm-hmm.
the blood very thick, and you can easily form clots,
Clot.
causing thrombotic effect. Yes, so that is it. Should we close or maybe last one?
Two is within the normal range.
Last one.
Which one?
The white blood cell 4,000 to
I said it. Yeah, I said
5,000 to
52,000.
10,000.
I said 52,000. You know.
She's asking for normal range.
I was
Yeah, the
thinking
normal range.
52 is within normal range.
5 to
No,
10,000. 5,000 to
you forget
10,000.
it. It's 5,000, 10,000. This one I said
Some will also say
52,000.
4,000 to 11,000.
Are you there? So note the values well. If 5,000 is different from 50,000, okay?
Okay.
Okay. So okay. So my last question: which client should receive filgrastim? 1, a client with chemotherapy-induced neutropenia. 2, clients with anemia from chronic kidney disease. 3, clients with thrombocytopenia. 4, clients with iron deficiency anemia. This is easy.
1.
1.
1.
1.
Yes. Yes, that's correct. My last question, sorry. Let this one be my last question. There we go. This is very interesting. Let me see if you get it. The nurse is caring for a client receiving filgrastim. Which finding requires requires immediate intervention. Which finding requires immediate intervention? 1, mild bone pain. 2, low-grade fever. 3, oxygen saturation of 89%. 4, injection site redness.
Injection site redness. D.
Are you sure?
Take the
Will you
question
tweak
over
that one
again,
and
sir, please.
Low grade fever.
I'll take 3.
Okay, let me take the question again.
Low grade fever.
The nurse is caring for a client receiving filgrastim. Which finding requires immediate intervention? 1, mild bone pain. 2, low-grade fever. 3, oxygen saturation of 89%. 4, injection site redness.
3.
Fever.
3. Take
It's
3.
oxygen saturation of 89%. Okay. Yeah,
Yeah.
so one thing about filgrastim too is that it can cause some acute respiratory distress syndrome, like ARDS. So signs can be maybe hypoxia, dyspnea, pulmonary, issues. Okay. So bone pain, remember bone pain is common.
Expected.
Yes, it's expected. And injection site redness is also expected. Low fever, remember filgrastim itself doesn't suppress the bone marrow. So you just monitor. If it's like chemotherapy itself, then that is fine. But comparing 89% of oxygen saturation and low grade fever in relation to filgrastim, the answer is oxygen saturation. All right, I think we've done very well today. I hope today we've learned one or two things to add up to what we know.